Now they're really doing good. So now they're
Like the pilots are talking about, well, those kids don't get out of the way. I guess we're just going to put it in the dirt and just blame because they're not going to run over two kids. But it's fascinating. A lot of things went well, but a lot of things could have been done to avoid this happening. So why is this anecdote? Why does this matter? Why am I talking about this at a surgery grand rounds? Human error is very predictable. Maybe not very predictable, but predictable. We all expect mistakes to happen despite even the best preparation. And these aren't necessarily technical mistakes. Sometimes they're judgment mistakes. Experience is not immunity from error, but it can be protective or like mitigate error and make a small problem becoming a big problem. Systems and surgeons should expect error. And aviation in particular doesn't ask how to eliminate human error, but asks how to survive it. I read the FAA report. There were 18 pages on human error, and most of it was just talking about how they didn't really do the calculations right. And then there were 62 pages of the report about how how Air Canada and Boeing kind of messed this up and made it so this was able to happen. They weren't crucifying the two pilots wasn't going to fix this. Fixing the airplane and fixing the system is how they thought they could keep this from happening again. So we'll talk a little bit about science real quick. So there's a concept of cognitive workload, which I think is very interesting and very relevant to us, especially in surgery. There's, basically three areas that it comes down to. You've got the intrinsic load, which is, what makes a task more difficult? Like, so you're doing an appendectomy, like in this picture, challenging anatomy puts a little workload on the surgeon. Maybe it's a big cancer, or maybe it's a big mass or something like that. That makes things a little more complicated. Bleeding puts a little more load on the surgeon. They don't have the stapler you like, and they don't have the energy device you like. That puts a little more strain on the surgeon. So these are all like just doing the task things. That's intrinsic load. Extraneous load is like, hey, Dr. Friel, the charge response to how much longer until the case is done. The intern very kindly wanting to run the list or something like that, and maybe it's not the best time, maybe the device rep has a little funny quip to say. These are all things that kind of provide interruptions to what you're thinking about. Auditory distractions, there's like the stupid pulse oximeter thing that for the arm, they've got this funny device and it just beeps all the time and nobody knows how to turn off the beeping. So unpleasant beeping. Maybe you don't like the music they're playing. They're like, you've got one case done and it took 3 hours longer than planned and now you have 3 more cases after that. These are all things that kind of put a little strain on you from externally. And then there's task performance, which is, basically, have you done this procedure a lot? How good are you at doing the procedure? Is this your expertise? How much experience do you have? So you can see, while experience is one small part of this, and, perhaps is a bigger part than we think, there's so many other things that we can control or potentially can control, and some things we can't control that put workload on the surgeon. And not just the surgeon, but the staff. There's a lot of ways to measure cognitive workload. I think the most straightforward ones are anybody who's an Apple Watch or like a Garmin or something like that knows it measures like your heart rate variability. These are pretty well defined like measures that you can use to say how stressed out you are. Like when your heart rate variability is out of your normal parameters, it indicates that you're stressed. If your heart rate's up, pretty straightforward, there's stress. Yes, you can look at, pupilometrics and some other things like your respiratory rate. Sure, we could operate with EEGs on. I guess that could happen. But I think, we have pretty handheld things that can give us pretty objective data on how much stress we're experiencing at a given time. And I think it's interesting data for us to look at So the big point to take from this and from these studies, which I didn't have a good figure for it, but multiple studies have demonstrated that decision-making degrades before the technical skill does. When you're overloaded, you may still be able to do clamp, do everything normally, but your brain is maybe a step behind where your hands are in a lot of cases. And that's a hard thing to recognize sometimes in the moment. If you think about this pilot, and probably every single person in this room can think of a situation, you're in a similar situation, the jump seater, the cabin crew, the co-pilot, the ATC, everybody's asking questions. The ATC is like, how many souls do you have on board? How much fuel do you have? The cabin crew is like, the crew's all the passengers are stressed out. Nobody knows what's going on. The co-pilot's just trying to, help you keep the plane aboard. Everybody's vying for the attention of the captain. And as a result, the focus just like narrows and narrows and narrows until all you can see is that one thing in front of you, which might just be keeping the plane in the air. Aviation, they're great about training. They train for all kinds of emergencies. They train for a single engine out. Nobody ever trained for both engines out for this kind of plane because they would think it would never happen. The airplane's stable, but it's in a dangerous situation. And I kind of alluded to this. The air traffic control couldn't even see the airplane because the transponder wasn't working. So they kind of fall back on their ABCs and their ANCs. Something interesting, I think most people have heard about this or some variation on this, is that there's an area of optimal performance when it comes to cognitive workload. So we talked about all the things that go into cognitive workload, and you look at this and you see this like area of optimal performance is right in the middle. I think this is pretty easy for us to look at. Like, you've seen a circulator who is like way up here, has no idea what's going on. And I'm not thinking on like the circulator, but think about it. Somebody who's like doing a case they've never done, you're asking for equipment they never heard of, they're all the way up here. They have no idea. They're not performing optimally because they're very stressed out. Alternatively, I think everybody's probably worked with, you have a case, maybe something doesn't go quite right, the resident feels really bad, and they maybe shut down a little bit. They go down to that low. They're not as engaged in the case anymore. And as a result, now the attending is having to do everything by themselves. And I think this is very real. I think, and there's variations on it too. The resident could be completely over their head too, and now they're in that high stress area too. The attending may be thinking of things that the resident's not even thinking about. The resident's like chilling over here, and the attending is up here because they're thinking of all these things that the resident's not even thinking of. So there's this idea of like, how do you get to that optimal level of performance where everybody's engaged in the case, everybody's thinking, but nobody is either disengaged or overwhelmed? And how do you design, I put this picture of a nuclear power plant here because they think about this all the time, is how to design equipment that keeps the person looking at the equipment engaged, not overloaded, but also not bored. You want to keep the person who is managing this challenging equipment engaged, but not bored. So there's some methods you can use to optimize the workload. One thing that's obvious is shed and offload tasks that can be. If you can trust, if the circulator is overloaded, they need to get help. They need to get get the charge nurse in there, get Lindsay in there, whatever. Like find somebody who can figure out what needs to be done. Same thing with surgery. Potentially, this is when you call in the partner, and the senior partner goes and takes over that part of the case, does the retraction for you. Now you don't have to do the retraction. You can just focus on trying to fix the problem. Something like that. Heart rate variability could be used to recognize when overload is approaching. Maybe they stop interrupting you until you get through the hard part of the case. Sometimes we don't communicate the hard part of the case. You can have a sterile cockpit, which is like something using like at takeoff and landing, people should not be talking except for the pilot. At the critical portion of the case, maybe people shouldn't be talking. And we have to communicate that. If you're doing a really long case, consider a break to let people kind of get back into that optimal stress zone. I know, sometimes that's not an option, but it's something to consider. Emergency checklists, I didn't want to talk much about checklists, but there are emergency, it's something to think about is checklists for when every step matters. Like if you're about to clamp something and you need to give heparin, making sure that happens. I'm not saying we need to have 1,000 checklists for every single thing. And I think surgeons by themselves do a lot of checklists in their head when they're doing procedures. Just like making sure we have, the devices we need to control bleeding if there's an issue. We do it a lot. We think through the steps, the critical things we have to do before we can move to the next step. And pilots, they know these checklists forward, backwards, left, and right. Like they're never looking at this checklist for the first time when they're using it. This is something that's a tool in their toolbox, and they're just refreshing themselves and making sure they don't miss a step. And I think that's something, to consider for certain things that are very, very high risk, like a T-car timeout, or like an EVAR timeout, or like a TAVR timeout. Before you deploy the valve, everybody needs to stop and just make sure we've done all the things we need to do before we deploy the valve. And then, minimizing intrinsic load, predictable equipment, and a team that understands what's going on is ideal. And obviously, there's only so much control we have over those things sometimes. But this paper kind of talked about, all these things we can do to make that workload lower. Train to offload, train to have people take over these tasks when they can without having to say anything. The co-pilot by default is always the one talking on the radio. The pilot flies, the co-pilot talks on the radio and does these other things. The attendants manage the passengers. The ATC makes sure the plane is flying in the correct direction, and the pilot, just focuses on flying the plane and coming up with a plan, and then everybody else executes the plan. And I think this is something that we do a lot. I mean, especially when all we do is work in teams. Either it's on the floor, in the OR, we're always offloading stuff, and we don't even have these understandings of like who's supposed to do what. And we don't even say it sometimes. People just know in surgery, which is kind of interesting. Sometimes it does have to be said, but not always. Okay, so this incident, the Gimli glider, was like a near miss. I mean, you could argue it's a near miss, that changed the industry. Rather than writing it off, they basically, I think they grounded all the 7.6s. They made sure they redid all the fuel calculation programs. They changed the way they did the training for the pilots, and they also they made sure that all the fuel gauges were working correctly. And something that they do in aviation that's really important, both in commercial and military aviation, is a debrief. We've talked about this a little bit, or we talked about this a fair amount. EPAs are something that are becoming a bigger and bigger thing, and now they're required by the ABS to graduate in the next 5 years. It's a form of debrief is probably the most important part of any flight, especially like a military flight or something like that. All they do, they might fly for an hour and then talk about the flight for 3 hours. We don't have time to talk about every single case we do for 3 hours. We probably won't need to talk about every single case we do for 3 hours, but it's good to review cases on occasion. Dr. Carter, for example, in Orange Clinic, loves to record all his cases, and he even narrates them and like gives feedback on the cases. And we watched the case one day with all the Orange faculty to talk about the way Andy sewed in this mesh. But it was really helpful. I mean, it's really helpful to have the feedback and talk through the case and understand what we could do differently and what we could do better. We get a lot of real-time feedback during cases, but sometimes it's nice to be able to take a step back after the case and look at stuff with the team. So here's a little example of crew resource management and how we do it. Say we have a gunshot wound to the abdomen, and we're already in the OR. Anesthesia, they're managing access and intubation if it's not already done. The OR teams get the equipment together. The charge nurses kind of coordinating staff, doing the count. The surgeons are planning. Ideally, the chief is coming up with a plan. The attending is double checking the plan and confirming it and making sure everything makes sense. Everybody should be thinking and communicating. The cognitive load should be balanced. Like the chief shouldn't be standing off in the corner not doing anything. The attending shouldn't be doing the same. Everybody's engaged in the case and trying to do everything they can to make it work the most successfully. And then after the case, every once in a while you got to reassess and make sure it's working. Make sure nobody's getting overloaded. Everybody's got their task and they're doing it. So this is kind of the idea of like a mental muscle memory and the value of simulation. So how do we get a team to the point where it can manage that gunshot wound? There's an idea of stress simulation. Like how do trainees or even faculty simulate stressful emergencies before they happen to them and their patients? And like how can trainees learn to manage problems or a team under stress? There's an interesting book I read. This is a stealth fighter pilot named Hazard Lee. He wrote a book called The Art of Clear Thinking. It was pretty interesting. One section that was very interesting is he talks about the F-35 training program. The F-35 is, the most modern aircraft, fighter aircraft in the United States military. And they were trying to come up with a new novel program compared to prior training programs because this was in an age where there was a lot of really highly effective simulation tools available, like virtual reality, digital simulation. Everything was coming together right at the right time. And something they noticed in prior training programs is there's a big focus on rote memorization and just memorizing the checklist. And like if you get off the checklist, people don't know what to do. If you get an unusual situation, sometimes people just make terrible decisions. And we see this in mock oral sometimes is you get just a little bit off the path that somebody was expecting, and an inexperienced person might do something crazy. Not crazy, but so people would often make spectacularly wrong decisions with that training paradigm. So they changed it a little bit to begin with concepts and then kind of build experience on top of it. So try to help them understand what is going on with the aircraft, what they should be doing at a given time, and then they let them just practice, either in simulators, in real planes, in all these different environments that help them kind of understand organically how the plane worked. So they kind of made this paradigm shift from like just wanting to like make sure people know how to do something the textbook way, creating these flexible problem solvers. I have a friend who I met through flight simulators who was an American Airlines first officer for the A320. And he's about 11,000 hour pilot. And he's going through his 787 transition. So he's going from one of those narrow body planes to a wide body 787. This is a picture of a simulator they use at what they call the Death Star in Dallas, which is like American Airlines training center. So just to give you an idea, he's already flown for 11,000 hours. He is a very accomplished pilot at this point. This is what he has to go through just to learn a new aircraft. So, an unspecified amount of home study. He said he studied for about 4 weeks of just learning the equipment. Like basically he had a picture of the cockpit on his wall and he just looked at it every single day and just made sure he understood what every single knob did. Then on a simulator like this, he spent about 2 weeks just learning procedures. Just learning emergency procedures, learning takeoff procedures, learning where the switches are that you flip at a given time. At about 50 hours of simulation and debrief, he's evaluated for all the emergency procedures. So before he's even allowed to touch like the real simulator, he knows how to do all the emergencies basically cold. He has at least the conceptual knowledge. And they actually have a nice special procedures and leadership training. So they do specific training on how to manage a crew in a stressful situation, and how to motivate people, and get them to do what they should be doing. And after that, he spends 3 weeks of flying with a check pilot on like flights with people on them, revenue flights, and then 100 more hours in 90 days. So the point of this is that while there is some flying and making sure he knows how to fly, almost all of this is just about training him how to make good decisions under pressure and how to know to react to every single emergency that he could come across while flying this aircraft. Poking a little fun, but not really. So imagine what the first inguinal hernia for an intern or a trauma exit for a chief is like. And I will say, I think we have pretty good training, all things considered for this, but just bear with me. So there's some formal education, but it's variable. I think different people have different experiences. Medical school, intern year has different experiences. People do get to experience things as they go, and we have special training, things like that. But it's some formal education, variable opportunities for debrief and feedback. Surgeons, we do a lot of learning on the job by doing, and it works in a lot of ways. We kind of jump into the deep end a lot, and that's how we learn how to train. There is obviously a lot of preparation and things that go into it beforehand, just like him. We're reading about the cases. We get feedback from our attendings before the cases. We talk about the cases, but it's really tough because there's not great simulation for at least the technical aspects of surgery that we have, especially open surgery. So what other ways are there? I just want to circle back to this real quick. One thing that I always thought was interesting in residency is you kind of graduate into being a leader just naturally. You, over time, take on a bigger role in a team. You manage more people and more people and more people until you're the chief of the service, and then you become an attending, and you're kind of in charge of a big team. It's kind of interesting. We do this with relatively little formal training on how to manage a team. I think, and it's not a critique of like our training program or anything like that. It's just in general, I think medicine, we don't always teach people how to be a good leader. And I do think it's something we should think about. American Airlines, he talked about this whole course he did on formal training of how to manage a team, distribute tasks. They have a big focus on maintaining situational awareness when you're doing a complicated task like flying an airplane. And they talk about how to like expect and manage error, and like how to deal with it in the moment without getting overwhelmed. And there's a big emphasis on safety culture. I think we have a good emphasis on safety culture too, but that may not be the case everywhere. And by safety culture, I mean people being willing to say, I don't think this is right, or I think something bad is going to happen, we should stop. Or being able to say, this didn't go well, we need to do this differently. I actually do think we're pretty good about that, but it's a core tenet of their professionalism and leadership training is saying, you know, we want to know about these mistakes so we can do better. I think one thing that we as surgeons do very well at is mock oral training. I think mock orals is such good simulation. Yes, you're not simulating technical skills, but it works in so many different ways. It's almost like practicing these emergency procedures that he's doing. You're going through a case, and then you go through all these variations, all these branch points in the case in a good mock oral scenario where you're learning about how the case could do differently and testing your knowledge and pushing your knowledge in different ways. And it's such a low-risk way of learning to think like a surgeon with good supervision. I think we do a particularly good job about it. And one other thing I didn't really write in here is like it also simulates stress for multiple reasons. One, you don't want to look stupid in front of your faculty. So inadvertently, maybe not the right kind of stress, but it does make stress. And there's a time pressure. You have to get through the scenario fast enough. It's just really high quality simulation. And when you do it with a faculty that knows, an experienced faculty in doing these mock orals, you can learn a lot about how to think like a surgeon. I made a little thing about AI. You know, I think you can simulate this within reason, but oversight is so important so it's not feeding you incorrect information. You can give it a textbook and say, I want to, you know, I've done this actually, admittedly. I gave it, you know, the SCORE curriculum and said, these are all the things that could be tested on. Not the SCORE curriculum itself, but like the list of the topics from boards from the ABS website and a few textbooks. And like, you know, it can generate a pretty fair mock oral scenario, but I also know enough at this point to know when it's telling me something that is completely incorrect, whereas an intern or like a medical student may not. So I give that a grain of salt. So some future directions for surgery training and us, and like how we can do things. I'm not saying we have to do things like aviation does, but some things that they do that are good. So continuing simulation of intraoperative decision making with simulated stress early on. I think something that is interesting that we're going to get more of over the next 10 years, I suspect, is high quality robotic simulation. I think what's so cool about aviation is like you can basically simulate any flight with like a laptop and a VR headset and a joystick, and you can like go through all the procedures of any flight, and it costs basically $0. For us, if you want to simulate open surgery, you either need a pig and an anesthesia team and like all this other stuff, or you need a complicated moulage setup that also costs like $10,000, and then somebody to make the moulage and do everything, and then it's not even that realistic. So if you want to simulate actual technical stuff, it's very hard to do for open surgery. Laparoscopy is somewhere in between. I think the robot is probably going to be the real area where we can get a lot of practice with this, is as they develop more sophisticated training models, people can go through cases and have little surprises in them and learn a lot without having to do it on a patient, especially high-risk, low-frequency events. You know, detecting measures of stress in the OR, I'll say, you know, having the charge nurse or having the circulator go over and say, hey, Dr. Friel, the computer says you're stressed out. Maybe you should stop being stressed out. That might not be the most useful, but there might be other ways of, you know, using that data in a helpful way to make the team work more efficiently. Emergency checklists for the right emergencies, I think, can also be helpful. Things where you have the time to stop and where a single step wrong would mean disaster. I think checklists can make sense. And I think it's checklists that everybody should know, everybody should be familiar with, and you're just going through it real quick. I think appropriate use of AI for cognitive offloading can be helpful as well. And when I say that, I mean like, you know, maybe checking to make sure the case card has the right equipment, or like simple stuff that doesn't have a direct patient care impact necessarily, but things that take strain off of the surgeon and the team, things like that. And then debriefing. I think, you know, EPAs are good. I think, you know, we can't debrief every single case because if we're doing 5 cases a day, we can't spend 5 hours every day talking about the cases. But I think choosing good cases, not unlike M&M. M&M is a form of debriefing itself. but we can also talk about, the cases that go pretty well and where there's small things we can improve too. Because I think that's what, of the vast majority of the cases we do are cases that go pretty well, but we could maybe do a couple things better. And I think that's what that's an area we can work on. So in conclusion, I think, recognition of cognitive workload is the first step to like getting your situational awareness back. I think good training lets you focus on the problem rather than the process, and really understanding how we can do things most effectively. And then I just like to say thank you to my family and my friends and colleagues and everybody that's worked with me over the last 7 years or so. Thank you.
So Andy, that was a fascinating talk, and in many ways, I also hear your dad. I mean, it's the type of stuff he was interested in as well. So as I hear you, I hear Jeff, giving a similar type of talk about how he talked about fire chiefs, and all that kind of stuff. So I do think that you're right about a lot of things we could do better. Time and money is always the biggest thing. And that's the hard part. But I do find that the part that you're really focused on is that decision making is really, it's not always the technical parts, right? And that those, when we get in trouble, we were just talking about this, just 2 seconds ago. Like I got in a little trouble yesterday, and in the decision, I had to stay calm, and I'm a lot calmer than I used to be, quite frankly. And so you can get that with experience, but also making sure that you get yourself safe before you make the next move, right? And how to kind of manage that. And that probably is a very learnable thing. And I think you're right, it is probably a teachable thing. And I was thinking about the mock orals, like we deliberately make them stressful a little bit because surgery is stressful. And managing that stress is actually really, really important. And one of the biggest challenges, I think, as a surgeon is focusing on the here and now. And you've got someone upstairs who might be leaking. Your wife has called you because she's got an appointment you were supposed to be at and you're not there. Because all the things were happening to me yesterday, right? And trying to compartmentalize that and say, I have to put that aside for now so that I do not have the cognitive overload that I lead to making some really bad decision that can lead to a really bad outcome. That is probably teachable, right?
Yeah.
And yeah, so that was an excellent talk. I wish we could do all the things that you talk about, and maybe we can in some ways, and maybe we can do less first.
Yeah, it's too bad we can't, if an airline pilot flying across the Atlantic, you put your phone on airplane mode and then it's like you're isolated from, we can't really do that because of what you're saying. It's like there's patients on the floor upstairs and things like that. If only we could just turn everything off and just do the surgery.
The other slide I really liked was the one for your optimal performance. And, and I talked a lot with the mid-year reviews. Like I want all of you guys to feel a little stretched, right? Because I don't want you to be bored, but also if you're on the other end, you're not learning either, right? So you have to be the right resident in the right moment at the right time to get the optimal experience out of that. But I love that slide.
Andy, I really enjoyed the talk. In the movies, you see like when the propeller stops, the plane just plummets, right? So that's not the case.
No. I mean, and you know what's more interesting? I don't know if anybody's ever seen Sully. Sully's a great movie. Sully's one of my favorite movies. About the miracle on the Hudson. They're like most dangerous position taken off. They're slow. They're all dirty, and then both the engines go out, and they're like 1,000 feet up in the air. But they don't even fly out. They don't fall on the ground. He still glides for quite a while until they decide they can't make it to Teterboro and go on the Hudson.
One of the things I always think about as surgeons, as Dr. Frio said, surgery is stressful, right? And as you gain more experience, I guess people get used to it. But is that really true? I mean, if you think about people doing like very stressful jobs, whether flying a plane or being a surgeon, do they manage stress better than the average population? Or is there a higher burnout that we don't recognize?
I think that's I think it's very true. I think this proficiency expertise thing is real. Like, I think the more experience you get, the less you have to think about every single step of the surgery, and the more you can expect what's going to come next. I think that does lower the stress, being experienced. They talk about neurogenetics. I don't really talk about this too much, but some people, I think, just handle stress better. I think it's just the reality. And everybody's met that person who, like, is never flat. Like, they never show a sign. They have a perfect poker face. Some people are just better at it. I think it's true. But I do think that proficiency and expertise does decrease that load. And there's probably another aspect of it too, is like, somebody's really experienced and knows exactly what they want and has all the equipment they need perfectly set out. They're gonna have less stress too, because they always have what they need. The OR team, you're very predictable. I think that takes workload off too. I think that's something that's probably underappreciated in all this as well, is setting up your environment. Because we have a lot of control. Well, we have some control over our environment in the OR. I wouldn't say we have a lot of control, but there are things we can do to make it a better environment for us to do surgery, just like picking the music that works the best for you, or making sure they have the device you want, putting your phone on silent. There's stuff we can do. But I think you're right. I think what there is like, it's a power rule. At some point, there probably is diminishing returns. I think you start off as an intern, you have no idea what's going on, and then you get up to, you're a chief and you're maybe like up here, then you're an attending and you're like up here, and then once you're a super attending, like your department chair or what, you've been doing this you're into career, you're probably still like around here. That's my guess. Dr. Chin?
Great talk, Andy. I think the parallels that exist between UVA and UVA's history of what we do it works really well, but challenge a little bit. I feel like the areas where the metaphor or the analogy falls apart is the fact that as surgeons we have a different social mandate. Your points about improving simulation, training, work. I think where we get stuck as a field is how do we implement that within the social constructs in which surgery lives, right? The ethics, the litigious environment, especially in the United States. Like, how do you recommend to move forward, navigate that to implement some of the recommendations that you implemented?
Yeah, and I think it's a big challenge. And part of it is like, the way our training is set up currently, it's like there's a lot of focus on getting X number of cases, and it's hard to spend 6 months doing stuff on a simulator before you get into the OR. I mean, we also have work that needs to be done as well. Like, we need people to put orders in. We need people to see consults. We need people to, run teams. I think, unfortunately, the way things are set up, we can't. It's hard for us to do some of these things in the current framework of residency training without changing some things. I think, it's possible if we had higher quality simulation, you could have people at a higher level before they do that first case. But then, I had a very interesting conversation with Dr. Butler at the VA about this. Is like, he made the comment that, 20 years ago when he was in training, there would be no attendings in the hospital for some cases in the middle of the night. 20, 30 years ago, you might do an appendectomy and there wouldn't be an attending anywhere. And it was the epitome of jumping in the deep end. And he said, you matured very, very quickly back then. And now, he made a comment for better or worse, it takes more time to get to that same point. And would what I'm suggesting stretch that even more? It's possible. And I think it's hard to say. I mean, this is the balance of if we're still doing safe surgery, do we need to do all this? It's hard to say, but if it can get people to a higher level before they do their first patient contact, I mean, maybe it would be nice. Or as a form of remediation throughout training for stuff that you haven't done in a while. Was there another point too?
No, I was just curious about your comments. I mean, so it'd be great, right? Like if we could have some really cheap way to stimulate surgery instead of code. But we can't.
We can't, no.
So I think that's kind of where it's difficult. I think your point's are really valid. I was curious what your thoughts.
Yeah. I think the best thing we could do, if AI gets to the point where it can do mock rolls, like an intern who has free time could just go over a mock roll scenario and it could test them on the areas that they're weak on and give them a good scenario and really push them without requiring faculty, that way everybody could be kind of learning on their own. I think it'd be great. I mean, I think that'd be awesome. I wouldn't trust it at this point to be teaching an intern anything. At least not that kind of stuff. But I mean, I think that would be the best simulation we could do in terms of decision making. Technical skills, I think it is what it is. I think, there's little trainers for like you do your practice your anastomoses, you can mess around on FLS, you can do some stuff on the robot simulator. But for true decision making, I do think the mock rolls is our best tool.
The other thing I think, is really challenging a resident as you're operating is not just think about, like, start asking for equipment. Start being the one that says, like, I need this stapler, I need this, I need it, I need this. And even if you're wrong, like, if you do that, you're engaged, you're thinking about it, and you're putting yourself out there. And if someone says, I want that other stapler, then you learn, right? But if you don't try to verbalize that could be that's the decision making we're talking about, making those choices.
And thinking ahead and the next step in the case. Dr. Hedrick.
Yeah, it just takes Charlie. I mean, thinking about the most stressful case I have ever done in my life, which you can probably imagine, was Charlie's. And, just being able to pick the assistant, the staff, the anesthesia, the only case of the day, right? I planned the music. And and it was best technical.
The assistant.
The best technical case I've ever done, I think. And, it's how could we recreate that for every case that we do? Not to that extent, it's just not possible. But, it would make such an improvement.
Yeah. That's this. I mean, that's what the nuclear power plants do, is they set up every single interaction with like those reactors to be perfect, or as perfect as you can be. So, and the planes are designed very intentionally as well. Like, all the equipment's in the right spot, all the knobs are in the right spot, so it flows naturally, especially the modern ones. There's a lot of like thought that goes into that. I mean, even you look at like the staplers and stuff we use, like, they've hired consultants and like design engineers to make that fit in your hand perfectly and do this and that perfectly. So now we just have to make our environment as perfect as we can. That's a great point. Dr. Uzetta.
I'm just interested on your thought on this. I read an article kind of defending we're operating overnight, we're operating on the 20th hour, everybody's exhausted. And we've all heard our own mothers or our patients say, what do you mean you've been here for this long? He wrote about like, we've all been so tired and that we're in our driveway after driving home and you don't really remember the path back. Did I forget to stop at that stop sign in my neighborhood? And made it akin to surgery when you're operating on the 20th hour, that you don't want to think, that you want to have done it and you're exhausted. And so taking the thinking out of it, because even how senior or great, nobody thinks they're best at 3 a.m. So his idea was we should train a lot and train overnight and train exhausted, because we want to not think during surgery as much as we can.
Yeah. I mean, I think that's interesting. What would be interesting is to see like these numbers, like this heart rate variability and like things like that at night, and how it correlates, like have some of this objective data to see how differently these people are thinking and reacting at night. And we don't talk about M&M. We do talk about it sometimes. We'll say, oh, this case was in the middle of the night. Usually it's an EGS case if it's the middle of the night, so it's pretty obvious. But whether or not like the time that the case happens matters. I will say some of these cases we do, it's not the perfect case like Dr. Hedrick says. Your third start ends up being really, really hard. It's a routine gallbladder and suddenly, can't find the common duct, can't do this, can't do that. It's a subtotal cholecystectomy, and now you're, 9 p.m. and you're finishing up your case, and it's one of the hardest cases you've ever done. It's like, how does that affect your outcome? I mean, I'm sure people are not operating optimally at that point. I'm certain. Dr.
Yeah, I totally agree with that. We did look at that in cardiac surgery, small case of the first start. It's not so much how one individual is doing, but I think what you alluded to, what's really important is how the system functioning, and the systems are different during the day than they are at night. So I would say that it's really important to look at our own internal data, everyone's internal data periodically, to make sure that the systems are the same. for what you need for each of the cases. And to the last comment, I totally agree that I think that, I see a lot of folks who are really sort of anxious and nervous. And when you get tired, you're not able to do that anymore. That kind of the first thing that goes away, you become a little disinhibited. And if you have enough reps, like technical reps in place, then actually I see better performance out of people when they get their head out of the game, just a little bit. There's obviously a sweet spot. But the initial sort of overthinking, anxiety tends to go away a little bit after you're a bit tired.
That's really interesting.
Randy, it's been a real pleasure to work with you. I think all the attendees would agree. I would say that, not only have you continued to mature in the OR technically, I think, you've really become technically proficient and excellent. But I think what I've been struck with is that, you really care about the patients. And then you're understanding the management of the patients. And I think that's where, yes, it's analogous to sort of like an airline or pilots and stuff, but I actually think training in surgery is more difficult because we talk a lot about training in the OR. They talk about, like flying and stuff, but there's a whole other part taking care of the patient, right? We talk about, all these orders and, but that matters, right? Because before and after an operation, there's still a lot of things that, we have to understand about the patient and manage, whereas they have like, mechanics and other things. They don't really know about what's going on with the plane. So it is a difficult, sort of like a career, but I think, I'm really proud of what you've been able to accomplish and looking forward to, sort of continuing on as a trainee and I think you're going to be an excellent, cardiac surgeon.
Thank you, Rebecca.
Thanks.
Oh.